Welcome, everyone. Thank you all for attending our first Afternoon with Sean Mackey live question and answer event. We are so grateful to Dr. Mackey for making the time to be with us today and to share his knowledge, wisdom, and expertise. Before we begin, allow me to share some guidelines for the event. First, if you have a question you'd like answered, please click on the Q&A icon in the right side of your screen and type it there. If you can, please ask one question at a time so Dr. Mackey can properly answer it. If you have a follow-up question, please feel free to add it into the Q&A icon so he can respond further to your question. We know that many of the topics we will be discussing today are complex, and we may not be able to answer them as fully as we would like. However, if Dr. Mackey isn't able to answer your question as fully as we would all like, please save it for a future question and answer event so he can answer you in more detail then. Today, we'd like to answer as many questions as we can, which might mean some might not have the depth we might like to explore in a future event. As this is a professional meeting, please use respectful language in all areas. It is being recorded and it will be available online at Dr. Mackey's website. We will include closed captioning at that time. So thank you all for being here, helping us make this an excellent opportunity for everyone in attendance. And for those watching at a later time from the archived version, welcome. So let me introduce our guest today. Dr. Sean Mackey is the Redlich Professor of Anesthesiology, Perioperative, and Pain Medicine, and Chief of the Division of Pain Medicine at Stanford University. Dr. Mackey received his BSc and MSc in bioengineering from the University of Pennsylvania and his PhD in electrical and computer engineering, as well as his MD from the University of Arizona. He has served as principal investigator on multiple NIH and FDA grants to better understand the mechanisms of pain and translate that knowledge into safe and effective therapies. Dr. Mackey is the author of over 300 journal articles and book chapters, in addition to numerous national and international lectures. Dr. Mackey is past president of the American Academy of Pain Medicine. He co-authored the Institute of Medicine's report on relieving pain in America. He was co-chair of the HHS and NIH National Pain Strategy, an effort to establish a national health strategy for pain care, education, and research. So, with all that said, welcome, Dr. Mackey. We are so excited to have this opportunity to visit with you today. Thank you for making yourself available to us. Can you tell us a little bit about yourself? Let's start with your education and background. Where did you do your training?
Delighted to answer that, Andrea. Before getting into that, I want to thank all of you for joining us, for giving me the gift of your time, albeit virtually, and ideally answer questions that you may have. Traditionally, over the years, I've communicated via Twitter or other methods, but it's been mostly a one-way process. Send information out into the world, and some of it gets filtered back. I have tended not to use Twitter as a means of two-way communication. Topics that I'm researching, that we're doing clinical care, are highly nuanced. They're complex, and I haven't found Twitter to be helpful for getting complexity of that across. And so hence Andrea, who I want to credit for this, came up with the idea of hosting this hour together so that we could dive into more of the details in some of these complex issues. So briefly, I'm a faculty member at Stanford. I'm a physician scientist where I did my training here, so I've been here for about 28 years. I'm a pain medicine physician, and my life's mission is to better understand the problem of pain, translate that knowledge into safe and effective therapies that can help people like yourselves who are suffering from chronic pain. At a personal level, I'm the proud father of an amazing son. I'm the loving partner, a woman who is also a faculty member at Stanford, Beth Darnell, who also researches pain. My background originally, I come from a rather hardworking family. I'm the first person to go to college in my family. I've held every manual labor job you can imagine, and it gave me a sense of the importance of hard work, but then also giving back to the community. And so I'm in a blessed situation here at Stanford, and my mission, Beth's mission, is to try and give back and to make an impact in the world in the area of pain. And I think we'll hopefully talk a little bit more about that.
Thank you. May I ask, just because I think it's so fascinating, how many years of college and postdoctoral training did you have after high school?
Yeah, I did 18 years after high school, and
18 years.
18 years. I
So
know
in that
it's,
time, how many degrees did you accumulate?
I don't know. I don't count them.
Many.
Yeah, bachelor's, master's, PhD, MD, internship, residency, fellowship, a few other certificates. It doesn't matter these days. $5 you can buy those. I think what it came down to, Andrea, is I remember being in my 20s, and I was at Penn, and I was at a pizza shop where I could get cheap pizza because I was a starving student. And I was thinking to myself, if we take care of ourselves, all of us, we don't eat too much, drink too much, smoke too much, we're going to probably live into our 80s, average age these days, 80s, 90. And I thought, spending a third of my life in training was a good swap for having control of my life for the next 2/3 of my life. And so for me, it was a reasonable equation to focus and get the training I wanted. And I was simply somebody who couldn't decide between my interest in technology and innovation, which was manifested through engineering, and my interest in helping people in healthcare. So I ended up doing both and bringing those together. And that is what informs a lot of my research.
Thank you so much. How long have you been in your current position as chief of the Division of Pain Medicine at Stanford?
Yeah, a long time now. I think it's 16 or 17 years, and really excited about what we've done in building a team of people. We've got about over 120 people, I think, in our group, an interdisciplinary team. So the vision has always been that because pain is so complex, you have to look at it through multiple lenses. You need to look at a person through multiple perspectives. And so I've hired and mentored people from different medical specialties, anesthesiology, PM&R, neurology, internal medicine, psychology, nutrition, physical and occupational therapy, you name it, and built a comprehensive center to be able to look at a person and not just, again, their pain, whether it be in their back, a headache, but look at them as a whole person and work towards improving their quality of life.
Wonderful. Thank you so much. Let me move on to some questions now from our audience. Let me just move on to that. So questions from the stage today. Let me just click on those. 1 second. Okay, just a moment. So we have a question here, some of them very complex, so I'm going to start with some of the smaller ones. For the moment, can you tell us a little bit about the Empower study and its relation to the value study and what the status is of the value study at the moment?
Yeah, delighted. And they are, in a way, linked, which will become clear. So to be clear, Beth Darnell is the leader of the Empower study. And the whole basis for Empower was that there is a segment of people who would like to find a way to reduce their opioids. Not for everybody. Some people are happy with the doses they're on. They're happy with their opioids. It's helping them. And neither Beth nor I were interested in changing that. But there is a segment of people who wanted to come down because they were experiencing side effects, because they didn't like the way the opioids made them feel, or they weren't clear that it was actually helping them. And so she worked with a community physician in Colorado who had a group of patients that wanted to wean down, But as people know, it's often very challenging. And so what she did is provide a supportive environment and a close physician-patient relationship to help people wean down compassionately. So the whole Empower study is now to test whether giving support to people who want to voluntarily come down on their opioids, not necessarily to off, mind you, but just reduce their dose, does it matter whether they just do it on their own, or does it help if you provide them with supportive care? And so what we do is we randomize people to those two groups. And we did this over the national study. So the idea is to have a broad representation of patients. And we recently just wrapped that study up, which we're just about ready to start analyzing the data and find out the results in this voluntary, compassionate opioid weaning study. Now, what we found is that when we were recruiting patients, there was a large number of people who didn't want to wean down. They were happy with their dose. And I was reflecting back when I was on the Institute of Medicine committee for relieving pain in America. And we were all discussing what is the number one biggest research question that we have in pain in society. And I'll tell you, at least in my opinion, what the number one question is that we still need to answer in society. What is the benefit? What is the impact of long-acting opioids and prescribing on people with chronic pain? We still do not know that. We don't know for whom opioids work and for whom they don't work. There's been a lot of rhetoric. There's been a lot of drama around this, people who have opinions, but we don't have good quality data. And at this point in time, the NIH hasn't been interested in studying this. And so what we decided to do was invite people who were on long opioids, chronic opioids, and just ask, can we watch you over the course of a year? Meaning, can we just send you a few surveys and see how you're doing? Nobody's done this. Because we wanted to figure out, are they helping people over the long run? And so we went out and recruited those people who did not want to join into Empower. We invited them to join into Value. And we've just been sending out a few surveys every now and then. And it's a battery of surveys because we're trying to understand for whom do these work and under what settings. And we finished up the recruitment for that. We got an overwhelming response on Value, and we'll start analyzing that data soon, and then we'll share it with you and with everybody else what we find.
Thank you so much. As a follow-up question, Koa asks, in the Value study, why were there so many questions about substance use disorder?
Yeah. So one of the key things that everybody is trying to understand is what is the role of these opioid, misuse-related behaviors and the use of opioids for chronic pain. And so one of the questionnaires that we put in there is based on the DSM-5 definition of opioid use disorder, which is 9 questions. And you get a severity of opioid use disorder with those 9 questions. Because we wanted to find out for people who may have, most people, by the way, we just expected would answer no to those questions, and that's fine. But we knew that there may be a few people that answer yes, and the question is those people who are having problems with opioids, having problems with control, compulsive use, were they getting into more problems with opioids than those who were not? And we don't know yet because we haven't looked at the data, but the data will ultimately tell us something. And if I didn't answer Koa's question, feel free to reframe it.
Thank you. We'll look in the medical board. Now, I'm going to
By the way, just also, if I can just say, Andrea, because sometimes the question comes up, all the data is de-identified, meaning we don't identify the individual person when we're analyzing it. We're not going to be reporting back any of the individual data to any physician, insurance company, legal authority. This is a research study. Everything is, HIPAA protected. And even we, when we're analyzing it, don't have access to information at an individual level. So I just want to put people's minds that we take data privacy as sacrosanct. It is absolutely critical. And I'm sorry I interrupted you, Andrea.
No, it's a very important point. Thank you so much. So we have some questions that I'm going to paraphrase just for the length. First, Anne would like to thank you for the work you did with the California Medical Board and the revised opioid prescribing guidelines. And I know that we all join her in thanking you for your involvement in that. So in the first part of her question, she asks, what can higher dose patients do to help physicians and policymakers understand why patients and clinicians feel these medications are beneficial for them and not causing harm, if this is indeed the case for the patient?
Yeah, well, my hope is that studies like the value study are going to be helpful for that, because at the end of the day, it's going to be data that drives the major policy decisions. The legislators want to see published papers, they want to see data. And I would say that that is going to be one major thing. I think another aspect of this is for people to hear your voices, but hear your voices in a thoughtful, calm, considerate manner, and come together as a group and fight for your rights. So, by way of example, when we released the Medical Board of California revised prescription guidelines several months ago, there were a number of patient advocates that showed up. And I got to tell you, and Andrea, you were on that, I think you were on that call. People handled themselves so incredibly well. Everybody was calm. Everybody asked very reasonable questions. They had criticisms of the Medical Board of California guidelines, minor tweaks they recommended. And, all the medical board members listened, they took notes. And when we debriefed afterwards, I'm not on the Medical Board of California, I was a senior advisor, but they were all appreciative of what the patient advocates had put forward. That type of model of bringing people together in a focused way is so incredibly powerful.
Thank you.
And yes, I hope to be able to build on that with some of your other questions. I think what patients have done in coming together and making societal changes are just phenomenal. Sorry, Andrea.
Thank you. No, it was a wonderful event. And I was also really impressed with all of the patients who spoke up. And I do think that is the most effective way for us to speak. So I'm asking a question now for Penelope, who asks, why are pain patients being treated worse than even people who have substance use disorders? I think in her, if I may paraphrase, it seems more resources are being offered to patients with substance use disorders, and patients with pain seem to be perhaps lesser priority. Is that your perception? And if so, what can we do to maybe balance that out?
Well, first of all, I'm sorry you're going through this, and let me be clear, you're absolutely right. I think for the last number of years, the opioid epidemic or crisis has sucked all the oxygen out of the room. Is a term I use frequently. It's driven all of the narrative, and I have felt terrible for people suffering from pain. The problem is that I think that the addiction field has been more effective in engaging legislators and policymakers than we have been in the pain space. And the reason is because they put forward these incredible stories, and it's heartbreaking. Their sons, their daughters, their mothers or fathers, their brothers or sisters dying from opioid overdose. And that's a strong message to a policymaker. And it's true, people have died. most of the deaths, as we all know, is due to illicit fentanyls and their variants. But unfortunately, the opioids get tied inappropriately to the problems of chronic pain. And often they're conflated when, in fact, they may not be related at all. So getting to what do we need to do, it comes back to the same message that we just talked about before. It is coming together and pushing a message that chronic pain is important and that we need to do something about it. I think one of the big problems that we have in the area of chronic pain is that we're all fragmented. You've got all of these groups, everybody trying to advocate for their own chronic pain condition, whether it be fibromyalgia or facial pain or back pain or temporomandibular disorders. They're all important, but they act as silos. And so when you've got the addiction group, it's just addiction. They're all coming together under one voice. And what we need to do is find a way of bringing people together and fighting for the problem of chronic pain. There's also been, unfortunately, a bit of infighting within the communities where I don't think it has served the communities and all of us well. But once again, the message is coming together. I'm sorry, Andrea.
No, it's well said. And I think many of us share that same goal. So I know we're all working towards that. So thank you very much. I have two questions from Sanam. The first is, can you provide a brief overview of your current research focus on the biomarker project?
Oh, yeah. You're asking a scientist to talk about his research.
All right. Now keep it brief because we have a lot of questions to get to. And he has a follow-up. So.
All right. The whole thing about the biomarker project, again, ties in with my mission in life to better understand the individual with pain and to define safe and effective therapies for them. And we have to recognize that everybody's pain is different. Everybody on this call has different pain. And everybody's needs are different. And the problem is we don't have good precision medicine approaches to figuring out what works best for whom under what circumstance. And so the biomarker project is meant to characterize the person, the individual person, and their trajectory over time so that we can learn from them and ideally translate that knowledge into individualized therapies. Medicine is shifting. It will shift. We've all heard of the concept of evidence-based medicine. We all know that. And it's an aspirational goal. The challenge we face with evidence-based medicine as it's practiced is it's based on averages. On average, this group of people with this treatment are better or worse than this group. The issue is, I don't treat averages. I treat people. And those averages don't speak to the individual. And so I'm trying to understand the person. And that's the purpose of the biomarker project.
Thank you so much. And Sanam has a follow-up where he mentions that he is currently a recent neuroscience graduate, and he's highly motivated to go on to medical school with particular interest in the MD, PhD pathway. And he's interested in the possibility of joining your lab one day. Could you possibly give him some tips, perhaps, on what qualities or skills you might look for in candidates for those types of positions?
Yeah, I got to tell you, I look for the same three attributes in just about everybody, no matter who I'm hiring, whether it be for a clinical position, an educational position, or I look for people who have lived their lives through a sense of excellence. People who, whatever they've done, they've been passionate about it. They've thrown everything into it that they can. I look for people who are comfortably uncomfortable with the status quo, meaning however the world is now, you realize it can be a better place. And I look for people who are willing to take their God-given or learned skills and talents to make a difference in the world. Those are the
Thank
people
you.
I'm attracted to.
That is a beautiful answer. Thank you so much. Let me ask you a question about the National Pain Strategy, if you don't mind.
Yeah.
We have lots of questions about that. So a little bit, one question is, did you write the National Pain Strategy yourself? How has the National Pain Strategy been adopted by different institutions or entities? And I'm going to add, what is the future of the National Pain Strategy?
Yeah. Is it okay, Andrea, to say what is the National Pain
Yes,
Strategy?
sir. Yes,
Okay.
please do.
We should start, if you'll allow me. I think it's important for the people to understand a little of the history about this, because it all started with you. Folks, this all goes back to, we could start with 2009. But what happened is a group of focused people with pain worked together with the professional pain societies. So it was pain advocacies, patients with pain, worked together with the professional societies, American Pain Society, American Academy of Pain Medicine, and others. And they lobbied Congress to put forward the National Pain Care Policy Act of 2009. And they got bipartisan support of this, okay? Like, how often do you get bipartisan support these days? And
Not often enough.
the reason is because pain doesn't discriminate. It doesn't care if you're a Republican, a Democrat, a libertarian, an independent. It doesn't care if you're old or young or rich or poor. It affects everybody. So Senator Hatch and Senator Dodd, Hatch, a Republican from Utah, Dodd, a Democrat from Connecticut, came together and put this forward. The idea to transform pain in this country. And it didn't go in. But they slipped it into the Affordable Care Act. And think what you will of Obamacare. Doesn't really matter. They slipped this into the Affordable Care Act. And what was directed in that act was the following. They authorized an Institute of Medicine conference on pain. And they encouraged the NIH to aggressively expand research into the causes and treatments of pain, and to improve education and training of professionals in pain, and to increase public awareness. So Congress now has been directed to do something, because it's in the Affordable Care Act, it's law. And so what they did is they commissioned an Institute of Medicine committee to come together and address this. And I was on that committee. It was chaired by my former dean, Bill Pizzo. We brought 11 people together, researchers, clinicians, and people with chronic pain. It had broad representation, people with chronic pain. And we put forward the IOM pain report. And in that report, we put forward a blueprint for our country. A blueprint to institute a cultural transformation in the way pain is researched, cared for, the way we train people in health professions, public awareness, and the way we reimburse. We did what's called an econometric study, which means we did an assessment of the burden of pain in this country, and that's where we came up with 100 million Americans. Maybe, Andrea, you'll ask me questions about it because that's been controversial. And we came up with a $500 billion a year cost to the country. One of the things that we put forward, one of the recommendations, was to develop an action plan, because the National Pain Strategy, the Institute of Medicine Relieving Pain in America report was a high-level blueprint. It was 30,000 feet up here. Where are we in the country with regard to pain? Where do we need to go? But it didn't tell us how to get there. It wasn't an action plan. So in that, we directed the Secretary of Health and Human Services, then Kathleen Sebelius, to implement a national pain strategy. Long and the short of it is, HHS came to the NIH Interagency Pain Research Coordinating Committee that I was a founding member of, and they told us to do it. And I was put in charge. I co-led that effort. I did not write the report, but I did write a chunk of it. We brought together, Linda Porter and I from the NIH brought together 80 national people, clinicians, researchers, policymakers. We had a lot of people with chronic pain on that. So it had broad representation of people with chronic pain on the national pain strategy. And go to the end of the NPS, it's all published, and just look at the list of members there and their representation to see. And what we did in the national pain strategy is we took the IOM pain report with its 30,000-foot view, its vision for our country. We broke it down into 6 working groups. We broke it down into working groups related to prevention and care, professional education, public education, how we reimburse clinicians for the care of patients, disparities, because we know there's huge disparities in the area of pain, and then data, because we know that the data we have on chronic pain is just terrible, poor quality. And we put together an action plan, not only an action plan, it was how to get to that place we wanted to be. That's the NPS, is an action plan of how to enable that cultural transformation that we need to be able to compassionately care for people with pain.
And what happened once you published it?
It's the good and the bad, honestly. It's been a source of disappointment for me because unknown to me and the members of the committee, there was a separate effort underway to develop the CDC opioid guidelines. And we had gotten a little wind of it, just rumors that there was another group working on something around opioids, but we had no idea what was going on. They had no idea what we were doing either, because, the federal government's huge, as everybody knows. We finished up the national pain strategy and it just sat there, and we were, I finally went and I asked, why are we not releasing this? And I was told that they wanted to release them together. They wanted to release the CDC opioid guidelines and the national pain strategy at the same time. I thought that was a terrible idea. I happened to have just testified for Senator Collins out of Maine around pain and elderly people. And so afterwards, I went and approached her and I said, Senator Collins, this is just a terrible idea. Can you please help? And she called, and I called the secretary's office, and it went nowhere, honestly. And the reason was they thought that they could get more bang for the buck, more benefit by releasing both together. Whereas I was worried if you release the pain strategy with the opioid guidelines would again suck all the oxygen out of the room, would be picked up by the press, and nobody would be interested in the pain guidelines, and people with pain would be dismissed. And that's basically what happened. The CDC opioid guidelines came out and just took over the press, and it was a source of disappointment for me. Now, it didn't diminish the importance of the national pain strategy. It just meant that we did not get the public and media attention that I had hoped that we could get. The document itself and what is behind it and what all the people with pain, living with pain, and everybody else put into it, it still is important today as it was then. We have made some progress in various working group aspects of it. Our data is of better quality. We introduced pain questions into Healthy People 2020 and 2030, which is a national survey of people with all health, everybody in the country, and elevated that. We've done some work with getting better reimbursement for chronic pain conditions. Because the reality is, it is money that drives a lot of physicians here, and so we need to pay them to spend more time with you. We've done some better work in disparities, but we have a long way to go, and we still need to better, ideally, come together and call for implementation.
Thank you. Thank you very much. All right, I'm going to ask you a controversial question, if you don't mind now, so take a breath. Amy would like to know, what is your position on the use of opioids in the treatment of chronic pain?
Sure, sure. Um, I have a mantra saying that I usually give, which is, uh, I'm not pro-opioid, I'm not anti-opioid, I'm pro-patient. Meaning, I view opioids as one of many tools that I use to care for people with chronic pain. I've seen opioids benefit many people, positively transform their lives, and I prescribe opioids for patients. I'm rarely in the clinic these days, about one day a month, but I have a small group of patients I still care for. One woman with Charcot-Marie-Tooth syndrome, which is a bad nerve pain condition, who I've been prescribing opioids for 20 years. And she's doing, she's living her life. She's spending time with her family and with her friends. Leave her alone. And I've seen the benefits of how they've transformed people. And I've seen how opioids can destroy lives. And I have reduced opioids in those people for whom the opioids destroyed their lives and they became addicted. So it's not a black and white response, Andrea. It is patient specific.
Thank you.
I hope I answered your question, or
you did. And if anybody has a follow-up, feel free to ask it. Sally asks, do you even have a rough estimate? What percentage of people with moderate to severe chronic pain are affected by the reluctance to prescribe opioids? Meaning, how many people might benefit but are unable to access that type of care?
I don't know. It's a great question. I just really don't know.
Thank you.
I don't think anybody knows.
Yeah.
This gets into, once again, the issue around data. We don't have good data in this country or in any country around the incidence and prevalence of chronic pain, of the different treatments and the needs. And that's what we called for, in part, with the National Pain Strategy, is to get better quality data so that we can answer these questions for you and for the policymakers so we can make change.
Thank you. So Tamara asks, how does Stanford manage political pressures, especially around prescribing opioids for pain management? Do you feel political pressures from the government, the DEA, the Department of Justice, the medical board, or other political entities that you fear might interfere in the practice of medicine? And if so, does that happen?
Yeah, you use the word Stanford broadly, and I feel like I have to put the disclaimer in that I don't speak for Stanford, right? I'm fortunate to be employed there. I'm a salaried professor. Stanford is made up of probably about 30,000 people. It's a small city. Students, faculty, staff. If you mean within the Division of Pain Medicine, which I'm the division chief,
yes.
If you mean me personally, at the division level, we felt some of the pressures from the DEA and the Department of Justice, but probably not as much as community doctors. I think they were running more scared. And I think part of it is because everybody knows we take care of complex people and we get left alone to a greater extent. I personally have not felt pressure from it. I just kind of keep my head down and try to do the best thing for the patients. Now, what about political pressures and where I stand on that? I tend to, as I alluded to, keep my head down and focus on pain. Because I find that when you step up and get involved deeply around the opioid issues, that's all you spend your time on. And there's no time left over to focus on pain. Every once in a while, I see something that is going wrong. And I step up because I feel like people of good conscience have to take a stand. I did that in Oregon. Andrew, you may remember, they, a few years ago, were going to forcefully wean all patients on chronic opioids who were Medicaid.
Yes.
The most vulnerable people in society are people with indigent care, low or no income. They were going to take them all off opioids. And they had no alternatives. There was no solutions. And I said, okay, I draw the line there, that I have to step up and do something. So I brought together a group of patients. Andrea, you were instrumental in that, physicians, researchers, and I wrote a letter. We signed it. I sent it to the governor, and they stopped. And let me be clear, that was not by any means just my effort. That was a broad scale effort of where people stepped up and said, this is wrong.
Yes.
And that's the power of people coming together, once again, is in a focused manner, identifying something and putting that will to use. And Andrea, you've been so effective there. The other one was in the Medical Board of California guidelines more recently. I didn't like the last Medical Board guidelines. I thought they were draconian and they harmed people. And when I was asked to help out, I stepped up, and I was a senior advisor, as I said. And if you look at those guidelines, I'm rather proud of them.
Yes.
I think we all worked together, and it put the power back in the hands of the physician and the patient. We removed the hard limits. And we did say, with increasing doses, there comes increasing risks, and you need to weigh the risks, the benefits, the alternatives. But we put that power back in the hands of the patients and the docs.
Thank you.
And I'm hoping it can be used as an exemplar for other states.
Yes. And just as a brief follow-up, Dora asks, first she says hello, and about the California Medical Board opioid guidelines. She's just asking briefly, how can we best work with the DEA to sort of appreciate what you did in California there, and how can we broaden or amplify that message that you brought to your state? Is there a way to amplify that?
Yeah, thank you. First of all, that question came up a lot in the Medical Board of California when we released it. And the key thing to know is the Medical Board doesn't work with the DEA or the Department of Justice. So if you want to influence things, work with the medical boards of your individual states. That's the secret, is if the medical board of your state says it's okay, if they take something that's like what we did in California, the DEA and the DOJ are going to look at that very carefully, because it is the medical board that is setting the standard for medical practice.
Thank you.
That would be my advice.
Thank you. Dr. Mackey, we have 15 minutes left and so many questions. So I'm gonna try to, let's try and see how many of them we can get through. And this one, although it's not in the Q&A, I suspect it's something a lot of people would still like to know. With regard to grants from the NIH, from PCORI, do you get rich off of those? Do you personally, let me just ask it just the way we want to know. Do you personally benefit, or you have any sort of enrichment personally, or do any other researchers personally benefit from those large $10 million grants that we see?
No. The grants actually don't go to me. And if you're in an academic institution, the grants don't go to the individual professor or researcher. The grants go to the institution. So the grants are made out to Stanford University. I steward or direct the grants. Now, I am a salaried employee. So whether I bring in $0 or $50 million, my salary is my salary. That's it. It's end of. None of that money goes to increase my salary. Now, to be clear, for physicians in particular, the grants provide salary support. So if I get a grant and I have 20% salary support, all that means is 20%. If there's 5 days in a work week, I get 1 day that's bought out of my clinic So instead of seeing patients in the clinic, I'm doing research on that grant. I hope that makes sense, but I'm
And
not
that,
making any more money. It's
and that would include like clinic staff or clinic people that you employ to work on those studies. Is that right?
well, I don't employ clinic staff. I employ research staff,
Oh, I see. Okay.
research coordinators, postdocs. But even we're all salaried. We're just salaried.
Thank you very much. Okay, we have a great question from Michelle about the different terms that we're reading about descriptions of pain that
Yeah.
seem to be a little arbitrary and subjective to patients. Central sensitization, nociception, nociplasticity. Are there actual evidence for these types of things that are objective that one could say, let's say, oh, you have central sensitization and we know opioids won't help you. Can you tell us what the value of these terms are, and are they diagnostic?
Wow. And Andrea, I get it. There's a desire to get through as many of these as possible, and if there's interest in this space, I can come back for another session. And I'm trying not to get too professorial and ramble on. But
Yes.
I know. The challenge here. Some of these are nuanced questions. A lot of these terms have a strong scientific basis in either basic science or even clinical science. Central sensitization was introduced by Clifford Wolf out of Harvard, clearly shown in rodent models of pain, and even you can demonstrate in human models of pain. Where the problem comes in is when these terms are co-opted in the clinical world and they're used improperly.
Thank you.
Um,
That's fair. Okay.
Yeah, we have no test really for a general clinician to establish anything around central sensitization and opioids.
That's excellent. Okay, I'm going to try to get through because there's a few more hot issues that we'd like to talk about, and this one is a big one. Tell us about catastrophizing, please.
Oh, God. And I know I said the oh, God because I know you want something brief.
Yes, please.
Yeah, maybe we'll unpack that another time more deeply. Catastrophizing is a term that was introduced a year before I was born. People think I invented it, but yeah, I'm not. I wasn't alive. It was introduced by Albert Ellis, who is a noted psychologist, and it had nothing to do with pain. It is a coping strategy that we all use. All of us use catastrophizing. Again, put pain out of this. I do it in emails. It involves three things. It involves magnification or amplification of the thing. It's worse than we think it is. Rumination, we continually think about it over and over again, and we feel a sense of helplessness or loss of control. And I frequently say, for me, it's emails. I get so many emails. All I get is emails. I'm answering all day. I'm catastrophizing right. But it's healthy as a coping strategy because it motivates me and you to do something about the thing you're catastrophizing. And it's a healthy coping strategy until it gets to the extreme. And when it gets to the extreme, it causes changes in the brain. Hardwire neural circuit changes in the brain that connect with pain circuits. And it makes your pain worse. And that's been well established in research. The problem with catastrophizing is the same as those other terms that the listener was mentioning before, is that the term has been weaponized and it has been turned against people with pain and used in ways we never intended it to be used. And that's the unfortunate thing that I wish I could change.
Thank you.
But I'll just stop there.
Thank you. All right. Moving towards the closing part of our program, and we don't actually have to stop exactly on the hour if everybody would like to stay or can stay. But Tamara asks, and I'm very excited about this part. She does ask, what is precision medicine and how might improve patient care in the future? And what is the future of pain research? What hope do patients in pain have for our futures? Because it's been a pretty tough 8 years for us. Is there hope for the future? From where might it come? What are you seeing in the field of pain research?
A lot of questions there, Andrea.
Yes. Sorry.
Briefly, yeah, a lot of questions. Let me try to unpack quickly. Precision medicine is knowing the right treatment for the right person in the right context. So it means for the individual person and their particular pain problem at that particular moment, what is the best treatment? I've been doing pain management for 20 some odd years. I've gotten pretty good at it. I've done my Gladwell 10,000 hours. And for a typical person coming with complex problems, we're often right about 30 to 40% of the time. And so we go through this very laborious, frustrating process, trial and error of trying different things. Many of the people listening in have probably been through that. So what if we could actually make it more precise? Now, the field that is really invented this is oncology. And they do it in understanding the different types of tumors and the different types of genes. Imagine breast cancer and the BRIC gene, and tailoring, precision, targeting a specific treatment for your cancer. We need to get there for pain medicine. We need to not treat the average, but the person. And that's where my research and many others is going, is focus on the individual. I'm very hopeful for the future. We're making great strides. We still have so much work to do. And that's, once again, we're working together. We've been integrating more and more people with chronic pain into our research, listening to them and getting them engaged in our research. I hope that's something else you can do, is reach out and offer to help with the research.
Thank you. Is there anything else you would like to tell us about you, about your work, about your anything else about you that you'd like us to know?
Well, one, again, I appreciate the gift of your time and coming in and listening. It's a great opportunity to break down some of these nuanced, complex issues that I know have been on people's minds. So thank you for that. Two, I just want people to understand that Beth, and others, our missions in life, this is it. Like, we're blessed with these, with really nice lives. We work at Stanford, which is an academic Disneyland, and we feel this mission to be able to give back and to help people with pain. That's what our focus is. I want to reemphasize this this notion of coming together and making a difference. I think it was Margaret Mead who famously said, we are continually faced with great opportunities, brilliantly disguised as unsolvable problems, but never doubt that a small group of thoughtful, committed citizens can change the world. Indeed, it is the only thing that ever has.
It ever has. Correct. Beautifully said and stated. Thank you so much. And I want to just take a moment to thank everybody that's with us today. And Dr. Mackey, thank you for giving us so much of your time, your knowledge, and your expertise. If any of you have questions that we didn't get to today, or there's a topic you'd like to know more about, please send me a DM at my Twitter/X account. You can find me at aanders1987. And if there is enough interest, we can do more of these events. And we could actually do focused events where we talk about just one topic. Perhaps we do learn more about pain catastrophizing, or we really get into biomarkers research, or what can we do as a community to really be effective in advocacy. If you would be interested in such events, please send me an email or capture me on Twitter. So on behalf of the entire team who worked to bring this event to you today, we hope it has been an informative, uplifting, and encouraging hour to all, and to those who might be watching it later via the archive at Dr. Mackey's website, which is drshawnmackey.com. And with this, we will close today's event, and thank you all so much for attending. Good afternoon.
Thank you, everyone. Thank you,
Thank
Andrea.
you.